Hello, everyone. I'm Shali Prasad, the Executive Director of the Center for Global Health and Social Responsibility here at the University of Minnesota. Welcome to the Humanitarian Impact of Conflicts on Maternal Health and Beyond, Lessons from Ethiopia. We're excited to have you today. As we look around the map of the world, we do see significant concerns in various parts of the world. We are all watching with bated breath that the current situation in Afghanistan will not descend into something much worse. There is ongoing conflict in Syria that has been going on for 10 years now. And in the midst of a devastating pandemic of COVID-19, while climate change is in the back of all our minds, there has been an unfortunate conflict that has unfolded in Ethiopia. And as we know, wars and conflicts have significant effects on health, healthcare, and health systems. There is an abundance of literature that suggests that this can linger way past the time of the conflict. Today, we'll be looking at the humanitarian impacts of conflicts on maternal health and beyond, one of the most important parts of the overall health in a community. And as the title of our webinar says, we'll be looking at the lessons from the Ethiopian context. This is also where I would like to remind the audience that this is not a discussion about the politics or the history of conflict in Ethiopia. While those are very important, they're way beyond the scope of this webinar. This webinar is co-hosted by the Center for Global Health and Social Responsibility as part of the Women's Health, Equity, Empowerment, and Leadership Series and the G4 Alliance. My particular thanks to all the institutes and centers within the university that has been part of the Women's Health, Equity, Empowerment, and Leadership Series, and our partners at the G4 Alliance. Also, to remind you folks that the opinions expressed here are that of the panelists themselves and are individually represented, and they do not express the views or opinions of the employers or organizations that they come from. We'll have a moderated discussion with Q&A to follow. If you have any questions for the panelists or me, please type them in the Q&A box and I will feed them to our panelists. The session will be recorded and will be available for you to review at our event website after tomorrow. A live transcript of this webinar is available in real time. If you're interested, you're welcome to turn it on by pressing on the CC button at the bottom of your screen. And now it's my pleasure to introduce the panelists. Dr. Barb Frey is one of our first panelists here, is a senior lecturer in the Institute for Global Studies and directs the Human Rights Program at the University of Minnesota. Dr. Frey's research interests include gun violence in human rights, disappearances and impunity in Mexico, immigration, and human rights advocacy. And she lectures and writes widely on these topics. From 2000 to 2003, Dr. Frey served as an alternate member of the UN Subcommission on the Promotion and Protection of Human Rights. She was also appointed Special Rapporteur of the Subcommission from 2003 to 2006 to conduct a study on the topic of preventing human rights abuses committed with small arms and light weapons. Dr. Frey was the Executive Director of the Minnesota Advocates for Human Rights from 1985 to 1997. Welcome, Dr. Frey. Our next panelist is Dr. Joy Wright. She's a health advisor for Medical Teams International. Dr. Wright is a general practitioner from Sheffield, Yorkshire. After volunteering with community health worker programs in Uganda, Thailand, and Myanmar, she moved into humanitarian health, including during the 2015 Ebola response for Save the Children, and from 2016-2020 in Iraq and Syria with MEDAIR. She's currently based in London, UK, and provides support and guidance to Medical Team International's health program as part of the technical team with a focus on sexual and reproductive health. Currently, she's providing support to the MTI team in Tigre, Ethiopia, while continuing to work as a sessional clinician within the National Health Service in the UK. Welcome, Dr. Wright. A third panelist is our own Dr. Rahel Nardos, is an associate professor in the University of Minnesota Medical School and the director of Global Women's Health within the Center for Global Health and Social Responsibility. Dr. Nardos was born and raised in Ethiopia and moved to the US for further studies. She's trained as a urogynecologist and spent 1 year as a staff surgeon at the Addis Ababa Hamlan Fistula Hospital and its multiple satellite medical centers in Ethiopia, where she served women with childbirth injuries. Since then, she's also supported the first formal urogynecology fellowship program in Ethiopia Dr. Nardos currently serves on the board of Worldwide Fistula Fund as chair of the programming committee. Welcome, Dr. Nardos. Our fourth panelist, if you notice, our fourth panelist will not be with us live. He couldn't join us and has sent a video and will be playing the video shortly. Our fourth panelist is Dr. Hallam McConnell, is an associate professor in embryology at Mekelle University and served as acting executive director of Tigre Comprehensive Specialized Hospital at Mekelle University in Ethiopia from November 2020 until May 2021. He's currently a postdoctoral fellow at the University of Maryland in Baltimore. Dr. Hallam trained at Addis Ababa University and Maastricht University in the Netherlands. Following his training, he served as a head of public and international relations office and as a chief academic and research dean from 2018 to 2020 at Mekelle School of Health Sciences. As part of planning for this webinar, we were hoping to get more people from the ground. And as you can imagine, that has been an impossible task considering the conflict on the ground and technical issues in accessing our expertise on the ground. Dr. Hallam himself has sent us a video, which we'll be playing right now. The video is at full volume, and if you're not able to hear it, please turn up the volume on your device.
So Dr. Hallam, so excited to have you here today. So you were the acting executive director of Tigre Comprehensive Specialized Hospital at Mekelle University from November 2020 until May of 2021, which means you were overseeing the operations of the teaching hospital during the early part of the conflict. From your own observations, what was the impact on the day-to-day operations of the hospital, and how did it affect your team's ability to provide medical and surgical care, but also training for your students and residents?
Thank you very much, Dr. Rahel, in having me, and I'm really happy to share my experience during the conflict in Tigray, and which was erupted in November 2020. Yeah, well, to begin with, when the war starts on November 2020, at the initial days of war, our hospital really faces an immense pressure from the trauma, from those who have been involved in a conflict, so both fighters and civilians. And usually it's mainly from the other, only from one side in initial times. So it was really, really quite difficult to manage the number of casualties coming to the hospital because most of the referrals in the periphery hospitals have been closed because of the fear and also because of the shellings. So most are coming to our hospital, and our colleagues and medical practices and our students intern and all residents are really feeling quite bad because they are working in every 24 hours. Every ward was full, and even the walking streets in the hospital was also, we just make a shed so that we can have at least some sort of treatment. So in the early times, it was really an influx number of casualties to our hospital and with high pressures. And in doing so, now the supplies are also depleted. And there was no continuous supply of medicine, particularly in ICU, those who need very intensive care. The drugs, antibiotics drugs, has been out, and we also have difficulty in fluids and so on. So it's the problem becomes multidimensional. It has an effect on the number, and it has an effect on the medicines and drugs, which is not continuously supplied. So in early times, and a day-to-day was really quite difficult for our colleagues on the ground, and also our hospitals, also difficult to manage all the coming outpatient. You know, our hospital used to treat around more than 300,000 patients per year. So in that times, and because of this flex, the number was really quite high, and that makes a little bit difficult to manage. So the day-to-day activity was really difficult in both logistically and also in human power.
And how did this impact your training program of the residents and students? Were you able to continue to train, or was this really compromised?
Yes, that's a very good question. So at early times, because of a sudden a sudden conflict started, and many of our residents have fled, and they left Mekelle, and they moved to a place where they came from. So it was only an intern students and also clinical 2 students only, and with our faculties. So initially it affects. So it has to stay around 2 months. Then after 2 months, we call our residents and also interns to complete the study. So it really affects because the residents or the intern students have been delayed in a graduation for 2 months. So it really affects our academic activity as a whole, not only in medical students, but also the paramedics has also left. So the effect is really paramount in both directions, academically and also clinical practices.
And then, I have a little bit of more of a specific question for you. So just from your own observations, what has been the overall impact of the conflict on maternal health in particular, but also just women's health in general, at least from what you've seen from your perspective?
Yeah, okay. Thank you very much. And before I go to the general part of the maternal part, it would be good if I explain also some of the problems that our clinicians has faced during this time, because some of them have been arrested and some of them has also been intimidated by different groups of the conflict actors. Because sometimes when they have been, because there was time that is not allowed to make a movement all over the city as a curfew. It was at 6 p.m. And sometimes, this of our clinicians, they may be called if there is an emergency. And because most of them are living nearby, if they start to move, some of them have been stopped by the conflict actors, and some of them have been warned even to be killed on the streets. And some of them have been taken to the custody, and they have been harassed and also. So it was really quite difficult for our clinicians or practitioners on the ground to work, especially after the curfew time. So these are really the bad things that happen because of the fear that some of them has left Mekelle already, and they moved to the other part of the country, at least things until they settle down. So when you come to your point, there are these maternal parts problem, or what happened in Tigray is really quite abundant, because in both aspects, the health institution and the health centers and hospitals out of Mekelle has been distracted by the conflict actors. It was destroyed, and and then the clinicians or the practitioners, they have been there, they are not around. So the mothers who have been in need of any medical attention have no place to go. Only they have to come to Mekelle, and to either the only viable hospital have been working in a conflict. So some of them even die of giving birth and along the way to come to the hospital. And some of them, even after they arrive in our hospital, if they arrive at a curfew time, nobody will give them treatment. And because most has left the hospital, it was because our hospital has been also occupied by the military man. And then people really fear at night that they could come and kill or may take us to the custody. Because of these reasons, the mothers who have been coming for any medical attention, they didn't get any service. So this is one part. And the other part is most of the girls and women in any reproductive age also flooding to our hospital because they have claims of being raped by the conflict actors. Not only raping, they also sustain some sort of injuries that needs a senior gynecologist and obstetrician to look on their body. And this, if you see all this and the magnitude of the maternal health in the last 7 and 8 months in Tigray has been devastatingly affected all the reproductive age of the girls and the women in the region. The maternal health in Tigray has been affected really gravely, and then it affects the whole society, both in physically and psychologically.
That's I can only imagine how hard that must have been to watch and to.
And if for interest, I think I have selected few 10 points of atrocities if necessary. I can also mention some of them in case for instance, let me take a few examples. And the first one was a 50 years old and para 5 lady from Zalambasa, was around 150 kilometers away. She has been diagnosed by our hospital as stage 3 cervical cancer prior to the war. And she was referred to Black Lion Hospital in Addis before the war. But because she cannot afford to go to Addis, she just went home, and then the war had broke out. And then she was raped by 2 military personnel and around her home. And she was brought to idol by a family member. So on examination, she has sustained vaginal bleeding and from the fragile cervical and vaginal mass, and there is an offensive foul smelling. And we have also 6-year-old child. She was also raped around Hausen, and she was also agitated, and her hymen is also tear, and she has also some sort of bruise on the perineum part. So these are the few examples of from all what I have mentioned, 553, and in general, 2,000 who have been voluntarily reported to the hospital and other health centers. And these are a few examples. So most of them have at least HIV positive and hepatitis positive. So you can see the scale and the magnitude of the maternal health problems in Tigray right now.
Thank you so much for that, Dr. Hailom. I really appreciate it. We all pray for quick resolution of this conflict so we can try to rebuild, you know.
Yes, we'll build it, but let's pray that this conflict will be resolved. So that's the only way that can be done. Thank you very much, and then sharing my experience with you and with the students. I'm really happy that if there is any question, I'm happy to answer later. Sure.
Thank you so much.
Thank you for that, and thank you, Dr. Nardos, for that interview. I was particularly struck by the two important issues that came up. One is the overwhelmed health system with the spike in cases, et cetera, with significantly decreased resources. And the second point, the mortal danger that the healthcare providers themselves are faced with every day by, during the curfew or being threatened. We sometimes forget that they also have their own individual lives, and they've had to go back to their own towns away from Mekelle during the conflict. So that adds to the complexity of the issue. And again, thank you for that. We're now going to transition to our panel discussions, and I'm going to bring in Dr. Wright. Dr. Wright, we understand that your organization, Medical Teams International, has been working in emergency medical relief in the Tigray region of Ethiopia since May of 2021. Could you tell us a little bit more about the work on the ground and describe the situation when it comes to the impact of the conflict on the health of communities, particularly women's health and maternal health? Dr. Wright?
Yeah, thanks, Shaylee. And good morning to all of you. It's great to just see this level of interest in Tigray and in maternal health. And as we've already heard, I think it's both the scale and the severity of the health needs in Tigray that that stand out. It's a situation that seems to continue to get worse, and it's a very challenging context in which to try and deliver humanitarian assistance. To give kind of a bit more sense of the scale, we're working in the northwestern zone of Tigre. So the latest numbers suggest there's 750,000 displaced people in that area alone, and that over half of them are at emergency levels of food insecurity. So it's really a huge need. We've been there since May. We're really focused on primary healthcare and making sure people have access to that. And we're doing that in three main ways. First of all, we've got a mobile team, that's made up of doctors, nurses, pharmacists, a midwife, a psychologist, and they're going out 2 or 3 times, they're going out to 2 or 3 different locations each week to provide consultations. At the moment, one of them is a sort of IDP settlement within Tigre town, and that used to be a primary school site. It had about 20,000 people kind of sheltering there after they were displaced, and it's hugely overcrowded. There's not enough services. It's not an easy place to live. So the team is there. They're providing kind of acute consultations for things like malaria, diarrhea. They also see any emergency cases that show up, and they're trying to, deliver nutrition treatment, antenatal care, family planning, mental health support. So it's kind of a fairly large package, but we see all of those pieces are really needed. The other place the team goes to is kind of a rural community about an hour or 2 out of Tigre. There they work in the main health clinic. That closed early on during the conflict. A lot of the equipment and supplies were taken. The building was damaged, the staff, many of them fled. And that's not unusual. That's the situation in over half of the health facilities in Tigre, that then they're still not back to being functional 9 months into this situation. So the team go there, they give consultations, but they're also trying to get that health facility online again with whatever's needed, fixing the generator, bringing in some equipment, doing some extra training. And what we've seen already in a couple of locations is, if you do that for a few months, the clinics are able to become self-supporting, and we can sort of phase out and start that process somewhere else. And obviously, just getting the pre-crisis health system back on its feet has to be a priority for a sustainable response. The third piece is using community health workers just to kind of make sure vaccines are being delivered, and people who aren't coming to the clinics are being picked up when they're malnourished or sick. So that's kind of the overview of our approach. I'm really happy to take questions on that if people want to know more. And you asked about the kind of impact of the crisis on health. I think, as we've already heard, it's been devastating. You have an enormous number of people who have witnessed conflict. They've left their homes. They might have been separated from family members. They've made incredibly difficult journeys, and then they're starting again in a settlement that probably doesn't have enough of anything. So you have this kind of increase in the population, high health needs, mental health, physical health, but you also have a real kind of reduction in the amount of healthcare that's available. I think certainly nutrition and food shortages have been one of the critical issues. I was there in April. I was already hearing from women about these impossible decisions. You know, do you feed yourself or do you feed your child today? And kind of, you know, fast forward to now, 4 months later, and 20% of the kids under 5 in our area are malnourished, at least half of the pregnant women. So that, you know, that already has a huge impact on outcomes, on kind of mortality for children and women. I think our other main concern in terms of maternal health has been the reports that people are just not getting to a health facility to deliver because the nearest clinic is too far away, or because there's no transport. You know, there's a handful of ambulances across the whole of the Northwest Zone. There's currently really significant fuel shortages, so private transport is just unaffordable for the majority. And you know, early on this year, there was still the overnight curfew that we already heard about. So you had women who were, you know, going into labour overnight, kind of coming up against difficulties, but it just had no option except to wait until the morning to travel. And you know, we've heard just really sad stories of women who you know, didn't survive that process, and that's obviously what we're trying really hard to intervene to avoid. I think also once people get to the facility, you know, there's a question about care that's available. Do they have the right drugs? Can they sterilize the equipment? You know, are there the other pieces available that save lives? So, you know, we know antenatal and postnatal care also save lives. So, yeah, there's work to do, and there's all of the things that we're trying to work with other agencies, work with the local authorities to try and provide, but there's enormous gaps at the moment. Yeah, I think I'll pause there.
Thank you, Dr. Wright. Dr. Nardos, if I can bring you in right now, I know for the past many years, 7+ years, you have been particularly passionate about capacity building within Ethiopia, and you've been involved with the Global Health Partnership with Ida Hospital, including urogynecology fellowship training. I know you're passionate about healthcare quality improvement and critical care capacity building. While we heard from Dr. Wright about what's out on the ground, what are your challenges right now? How has your work been impacted with the current conflict?
Thank you so much, Shaili. You know, first off, I just want to acknowledge what a privilege it is to have a voice to talk about this today, because, you know, as you know, my preference would have been for our healthcare partners on the ground to be the ones to speak today. So I just want to give you a quick background of our partnership. In 2014, my organization at the time, Footsteps to Healing at Oregon Health and Science University, was introduced to our colleagues at Mekelle University College of Health Sciences by my longtime mentor and founder of Worldwide Fistula Fund, Dr. Lewis Wall. He was at the time doing a Fulbright fellowship at Ida Teaching Hospital of Mekelle. And I remember Lewis, you know, reached out to me and said, you know, these are our people, and you are not going to find better champions of health and better partners. And he was right. The leadership at Ida was on a mission to make their healthcare institution the best, not only in the country, but also in the region. Ida is the second largest teaching hospital in the nation, and they are a tertiary hospital for a large catchment area, as Dr. Hailom mentioned, and people come from Tigray and northern Afar region and northern Amhara region states, and they also care for Eritrean refugees in Tigray. They also provide healthcare training for approximately, you know, 82,000 learners, ranging from medical students to residents to PhDs from across the country. They train people from all over Ethiopia and also neighboring countries. In 2015, I joined the Worldwide Fistula Fund as a board member, and along with Footsteps to Healing, we partnered with Mekelle University and Hamlin Fistula Hospital to launch the first urogynecology fellowship training program in the country. And this was approved by the Ministry of Health. The program was also supported by other partners like Maternal Health Fund and really a lot of faculty from our partner institutions in the US and Europe and Latin America. It was really a team effort. We have since graduated 4 fellows from the program who are now running the program and are training our current fellows. And until the conflict started, we were also engaged in various, like you mentioned, Shaili, training collaborations, including critical care and nursing, healthcare quality improvement and leadership, team simulation training and research, among other things. And so our members of our team were on the ground at IDER 3-4 times a year, around, for several years. The hospital quality improvement team that we worked closely with was launching various initiatives to improve maternal health outcomes, not only within the referral hospital, but also with the health centers and the district hospitals that we heard about that are no longer functional. And they have such a close relationship between the university, the School of Public Health, the quality improvement team, and the regional health bureau. And as a result, Tigray has led the country in lowering its maternal mortality and morbidity rate, making Ethiopia one of the only countries in Africa, or one of the few countries in Africa, that has actually met the UN Millennium Development Goals. So sadly, in the last time that we have actually been able to be on the ground was back in February of 2020, when the pandemic hit. And although initially we were still able to collaborate virtually, since the conflict started in November, we for several months, we completely lost contact with our partners. And of course, that was really a very terrifying thing. And we later found out that our partners at IDER were inundated with trauma patients, as you've heard, and severely ill pregnant women. And they were trying to do their best to save lives while they were running out of medical supplies, and even for a while out of electricity. And my partners told me that they were doing surgeries, including cesarean sections, without proper anesthesia or sterile drips and instruments for a while. Many of the healthcare providers had relatives in the regions outside of Tigray that were really affected by the conflict, and some of them had lost close family members. And when the banks closed down in Mekelle and no one was paid for months, and this was, really, it hit really hard everybody, and it was the hardest on the students and residents. Some of the faculty members told me that they used their own money to feed their students. Most of our colleagues are in constant state of shock from the sheer volume of suffering they've witnessed and the sense of helplessness. And I have to say, there are no mental health services for them at this point to help them deal with the situation. Our second year urogynecology fellow, who is an obstetric gynecologist at IDER, told me several stories about women he took care of who arrived to the hospital with obstetric fistula, which is a hole in the bladder or rectum that develops from obstructed labor, after these women were laboring for days while they were trying to make it to Mekelle to get care. He told me about the trauma of some of the rape victims and how he was struggling to figure out how to take care of them. There were hundreds of rape victims who were receiving care at the hospital, and some of them needed surgical intervention due to having trauma to their reproductive organs from the rape. He said that they needed mental health services, but no one was really trained to provide that level of care for these patients. So since the conflict started, our colleagues have taken care of about 86 women with pelvic floor injuries related to obstructed labor or trauma. They've done this while they were still dealing with their own trauma. As for example, our fellowship director and former graduate from our program was attacked in his home by armed men who looted his valuables and attacked him and his wife and injured him. And he continues to get up and go to work every day to take care of these women. We ourselves had to postpone the graduation of our third-year fellow by a year. And now I'm obviously not sure if he can graduate this year either, as the war has been expanding. But I have to say, you know, one silver lining of our program, at least, has been that our former graduates have stepped up and continued to provide the pelvic floor care for women across the country, including Tigray, and they've continued to provide training of our fellows. And that is, you know, what we call healthcare resilience. And I take a lot of comfort in that.
Yeah, thank you for that, Dr. Nardos. Dr. Wright, if I might bring you back again, and you mentioned, and Dr. Nardos mentioned some of the challenges at Michaela, and you mentioned a lot of the challenges out in the field. Here is a question from the audience. Lydia asked the question, has your team faced any backlash, like what Dr. Nardos was mentioning and what Dr. Hallam was mentioning? Has your team or team members faced any backlash from communities or the warring factions in Tigray?
Thanks, great question. And no, they haven't. I think actually, and this may be related to the kind of specific locations that we're in, I think actually what has stood out for me on this response is the level of support we've had from the community. You know, oftentimes when there's a big displacement, the host community that are receiving all of these people are slightly resentful of the extra burden, and that hasn't been the case in Northwest Tigray at all. Communities have welcomed the IDPs in. They've said, you know, you are family. They've shared their food with them even when they didn't have enough themselves. And you know, where we are outside of the main town, you know, it was actually the local community that did a lot of the kind of clear up of the health facility to allow us to work from there. You know, they were there for days, kind of sort of picking up all the rubble that had been left and making it a space for us to work. So for me, that's been one of the things that has been heartening in this response, just seeing that certainly within Tigray, there is a sense of solidarity still. Yeah.
That's good to hear, because we've heard some reports about members of MSF being attacked and challenges elsewhere are being, you know, caught in the crossfire. Dr. Frey, if I might bring you in for this discussion. We've heard from the other panelists about the challenges, particularly with providing care in the healthcare settings. We know that besides health of the individuals through trauma, there will be huge concerns about lack of access to food, water, or other resources, but also disruption of access to even basic needs. Could you weigh in on how conflict situations contribute to humanitarian right violations within this context?
Thank you, Shaili, and I'd like to first of all thank Dr. Nardos and yourself and the other panelists. It's a real honor to be here, to be able to hear your experiences and to understand more deeply what the challenges are that are in the field. Yes, I think that, you know, sometimes people look to the laws and standards and what should be done, and there's a real sense of frustration at the implementation gap, even in best of times. And we've seen with the global pandemic, some of the enormous gaps in healthcare systems that have impacted vulnerable people way more than the rest of us who have more privileged access. But certainly in conflict situations and humanitarian crises, even if they're not human-made, we see the impacts on health really dramatically increase. And oftentimes people look at numbers in armed conflict of dead, as a measure of what the casualties are in a situation. But we can see from these stories that casualties are exponentially greater just in the at the individual level and in society in general. But let me try to address briefly what the standards are in the humanitarian area, as well as the human rights area. So I make this distinction because in law, there are two sets of standards depending on whether there is an armed conflict in a situation. So the realm of international humanitarian law, or the laws of armed conflict, grow out of the international experience. I'm going to close my window. I have a barking dog. Was bothering me, if not the audience. So the international humanitarian law standards apply when there is a specific type of armed conflict, whether that's international armed conflict or sometimes internal armed conflict of the sort that we're seeing in Ethiopia. And those standards are really directed to the emergencies of an armed conflict. So they're things that are familiar to us as we think about what we know about war, which is that there is a distinction between non-combatants and combatants. So there's this fundamental paradox of the law of armed conflict that it allows kind of the worst atrocities of killings against combatants, but when a person is wounded or sick or out of the conflict because they're a civilian and they're not involved in the conflict, then their rights must be respected. At a minimum, they should not be subjected to direct violations. And those who are wounded, there's an obligation for the parties to the armed conflict to search for and collect the wounded and bring them in for protection and care, and to treat them without discrimination based on what side of the conflict they were involved in. So that's, wounded being non-combatants because they're taken out of the combat situation. There are also standards regarding the role of healthcare professionals, both the need to protect healthcare professionals and to respect that they are obligated by their medical ethics to treat all parties, treat the wounded in situations, and they should not be subject to reprisals based on their efforts to take care of the wounded and the sick. And then, of course, there are medical transports, including ambulances and other medical materials that need to be transported in times of conflict, and those must be respected and protected by all sides of the parties. So those are really basic. In larger terms, I just want to emphasize that there's a distinction between combatants and non-combatants, and non-combatants should be protected in their rights, their full extent of their rights should be protected, though states do have the ability to suspend certain rights like freedom of association or even the right to free speech during times of emergency. And what we see, as described by our speakers, is that you have people who become victims of the conflict, either because they're internally displaced or just the services, even if they're able to stay in their own homes, are reduced to the level that their fundamental needs are threatened. So the other cardinal principle of humanitarian law is that there should not be serious injury or unnecessary suffering that's inflicted even upon combatants. So there's a general prohibition against torture, even against combatants, the use of certain kinds of weapons like chemical weapons and lasers, certain kinds of bullets are prohibited at all times, even against combatants. Now, let's talk in general about the right to health, aside from this armed conflict situation. So in situations where there's no armed conflict, we won't call them peace, because as we know, that's a much more difficult place for states to get to in many times. But when there's no prescribed armed conflict recognized by the international community, then the states, or in some cases the parties that are in control of a territory, in control of the civilian population, are bound by their treaty obligations under international human rights law. So international human rights law is, there are some rights that can never be suspended, like the right to be free from torture, or the freedom from slavery, or in certain circumstances, the right to life. But the more positive rights, like guaranteeing the right to health, are more complicated. They require institutions to provide positive assistance to individuals, as we've heard, especially in the child and maternal health situations where people are really vulnerable. And so, the fundamental treaty that Ethiopia is bound by here is the International Covenant on Economic, Social, and Cultural Rights. And under Article 12, Ethiopia is bound to take steps to ensure the right to health. And what that means in real practice is that they are supposed to take positive steps to ensure that people have access to facilities, goods, and services, and to realize what is called the highest attainable standard of health. Now, let me just be clear that this is a legal standard that does not ensure the right to be healthy, but it is supposed to take in context an understanding of what is the highest attainable standard of health in a given situation. And in that regard, the Committee on Economic, Social, and Cultural Rights has interpreted the core obligations upon any state, including Ethiopia in this situation, to access to minimum essential food, to basic shelter, to housing and sanitation, to safe water, safe drinking water, and to essential medicines. Mm-hmm. So you'll see that's a fairly low standard, but even that we're hearing, from the reports of the panelists today, that those are really serious questions, especially when you have internally displaced populations or people, who are in desperate health conditions. So let me just conclude this part by saying that even in the pre-conflict times, the last time that the Ethiopian government reported on its obligations under the Covenant on Economic, Social, and Cultural Rights to the UN committee was 2012. And in 2012, that committee recognized in particular the high rate of maternal and infant mortality. And in its recommendations to the state, it firmly recommended that the state take steps to try to get more essential healthcare workers, especially into areas where where women and girls were not having access to even the most basic healthcare standards. So that was even in pre-conflict Ethiopia. So we see that these problems are exacerbated in this conflict.
Just a quick follow-up there, Dr. Fry. I know a lot of these violations we get to know after the fact. Are there mechanisms for monitoring? And I am asking this question, sort of dreading your answer there, because I understand the enormous challenge that would be involved in that too.
Yeah, it's, there are not adequate resources, even if there was political will to have international monitors who were able to call out a country and have it take responsibility. Having said that, there are about 20 different countries where the UN High Commissioner has offices. And I failed to check before this, but I wouldn't be surprised if Ethiopia has one of those offices. So there are often in-country human rights workers. They tend to, if it's a situation of armed conflict, they may be embedded with peacekeepers, or they may have a freestanding quasi-permanent office with the agreement of the government to be there. But even in those situations, the staff, the limited staff that are there, they are regularly reporting on the conflict. There are also the Human Rights Council, which is the legislative body of the UN, authorizes special procedures so that there can be specific country-specific monitoring and recommendations. As we all recognized in this field of human rights that a lot of the progress that is made is through the kind of naming and shaming of governments. So recognizing the violations that are going on and pushing them for changes. I would say that overall, the Office of the High Commissioner for Human Rights has more permanent capacity than it has ever had before, but there are a lot of conflict situations in the world where the High Commissioner can, at the highest level, make statements and urge governments towards peaceful resolutions and to address the human rights situations, but it's never enough.
Right. Thank you for that. Dr. Nardos, if I might bring you back in, we've had some conversations about how this conflict has affected you personally. You have close family and friends in various parts of Ethiopia. And in some cases, you've not been able to communicate with them, particularly with some of your colleagues for several months. What is the message you want to come out of today's event?
Thank you, Shaili, and thank you so much, everybody, for your really insightful comments so far. Obviously, this is a terrible situation, and now the conflict is, expanding beyond Tigray, affecting populations in Afar and Amhara regions. And my own family, is they're in constant fear of what might happen next, as am I. I think, my biggest concern, I would say, right now is even, when it comes to healthcare, beyond the immediate impact of the conflict that we're talking about, is actually the psychological trauma on healthcare providers that will have a lasting impact on their ability to recover and to rebuild when this conflict is over. I do worry that many of these healthcare providers, based on my conversations, may not want to stay in country or in healthcare after this experience. And that kind of brain drain will be a really heavy price to pay at a time of need like this. I also just want to point out, in situations like this, everything takes political angle because of the highly emotionally charged nature of war. People struggle to know who's telling the truth. And so many people don't believe that even what we're talking about today is true because of the highly politicized nature. And this is not unlike what we're seeing with the COVID pandemic right here at home. And I'm just hoping that this discussion today, highlighted the fact that conflicts have devastating and far-reaching impact on health of citizens, and by far the majority who suffer are innocent bystanders, like pregnant women trying to have their babies, or girls and women who are trying to protect their dignity. And of course, the impact is also on our healthcare providers who are in the front line. So, I really hope to see an end to this conflict. I really do, so that we can start the hard work of rebuilding trust and rehabilitating both citizens and healthcare infrastructures across the country.
Well said. And like Dr. Fry mentioned, we were already behind in health systems. So it'll take us much more to catch up, because some of these effects will last generationally too. So yeah, thank you for that. I'm going to open this up now for a Q&A from question and answer session from the audience. Some of you have sent your questions beforehand, and I will ask those questions. But I'm going to start off with two of the questions that have come up regarding aid or help. Mary asked a direct question: is aid getting to either? How can we help? We feel so impotent. And I'm going to ask Dr. Wright about that.
Thanks. I think it might be helpful for Rahel to also speak to Ada specifically. I'm not up to speed on what's happening for that particular hospital. I think in general, there is a significant humanitarian response in Tigray. One of the and certainly Eastern Tigray and Mekelle is being accessed by a number of aid agencies, providing different types of support from healthcare to kind of non-food items to food distribution. So absolutely, some aid is getting through. It's not as much as we would like. There is a huge need to scale up the response, and that is limited by a number of things, but one of them is funding. So looking at supporting those organizations is something that can be done from outside of Ethiopia. That's not a shameless plug for medical teams. That's just a general comment on humanitarian response. Yeah, I think you have to acknowledge that there is still active conflict going on at the kind of boundaries of Tigray with Amhara, with Afar, and that does mean that getting supplies through, getting people in and out is sometimes challenging, and that the region still doesn't have a functional. The phone network has dropped. The bank system is frozen. There are severe fuel shortages. So even when agencies have the capacity to scale up, there are a number of barriers that make that quite difficult practically. So hopefully that answers the question in a somewhat roundabout way. Rahel, anything to add?
No, I agree with all of those things. And I know I've been in communication with our IDER partners, in fact, and in my conversation with Dr. Hailom, what I understand is at least before this most recent escalation of the conflict, there was collaboration with the Ministry of Health closely and IDER. And even though in the first several months of the conflict, they were running into a lot of shortages, I think the Ministry of Health and the Regional Health Bureau were coordinating to get help to the hospital and wherever they could get the help without compromising people in the conflict. And so I think that was happening. I'm not sure in the last couple of months, because now we've lost all contact. Our team, actually, our collaborative team, had raised funds, and we have a whole container of medical equipment that our IDER partners asked us to provide, sitting here in our city of Minneapolis, waiting to be shipped. And we were collaborating with the Ministry of Health and all the partners there to get it there. But because of the escalation of the conflict right now in the last few months, we've decided to hold off sending it because, it's probably not safe at this point. So I think it's definitely compromising our ability to do more for sure. Hence the reason why the conflict, has to stop in order to get the help that they need.
Thank you for that. And one of the other questions that came in, again, Joy, you have answered this about how to partner with MTI, and that was not a shameless plug. That's absolutely fine. We have some information coming up in our slides down the line about how you can partner with MTI too. This question is for Dr. Frey, and this had come in from our pre-webinar responses too. What would it take for international involvement to end this conflict? Is there a standard or a bar that is set? Because it seems different in different places.
Yes, I think it's in recent years, there have been serious conversations about what's called the right to protect, or R2P, the right to protection, which somehow places an obligation on states like the government of Ethiopia to prevent mass atrocities. And if it doesn't adequately take steps to prevent mass atrocities in its own territory, then the idea is that the international community takes on some responsibility. That's what it is. R2P is responsibility to protect. I had the word wrong. The international community takes on the responsibility to protect people. So there is, at least in theoretical terms, an ongoing discussion about when what you would call humanitarian intervention, if there is such thing, is legitimate. And so, when you look at the conflict in Syria, Shaili, that you mentioned earlier, which resulted in, hundreds of thousands of dead and like serious and massive human rights violations, the will of the international community was such, and the politics of the international community were such, that there was never a realistic discussion of humanitarian intervention, even in a conflict of that proportion. We have other really serious political conflicts happening in places from Burma to now Afghanistan to this situation in Ethiopia. And while legally there may be that opportunity for the Security Council to have a discussion and choose to get involved in some way, the geopolitics of the situation are that without leadership by the biggest and most important members of the United Nations, like the US government, that kind of massive intervention is unlikely to happen. So short of that, the kind of steps that the Security Council tends to take are arms embargoes, some sort of targeted sanctions. The idea of kind of blanket sanctions has been disproven, over the years because of the damage it does to the most vulnerable, like what Rahel is talking about. You can't even get emergency supplies into health supplies into a situation. But this is the idea that you try to punish the individuals and companies that are benefiting or manipulating the conflict. So there certainly is an array of choices. It would seem to me most important that the African Union be involved in these discussions, and that that the first kind of conversations take place at the regional level before there's any kind of ramping up into an international. But this doesn't mean that there aren't steps that the international community can take, and the US government and other governments should be leading efforts to try and stop the conflict and negotiate with the parties. Ethiopia, it gets a lot of aid from the United States. We have a huge expat community in this country, which represents, of course, various of the ethnic groups involved in this conflict. So it's complicated, but the truth is the expat community can have a real impact on helping to shape a reasonable end to the conflict, and then have the discussion about what should happen politically afterwards. And I myself would call upon civil society groups like that to try to be productive in ending the conflict and not stimulating it further.
Right, good point. Here is a question for Joy. This is from Bayan, and he talks about the Tigrayan health system is based on a health extension system, and it's been destroyed. And he's asking a question, what will it take for things to get back? But I would want to post this in a slightly different way. From your experience, from MTI's experience, where are we in the conflict in terms of a recovery of the health system? Because in most conflicts, there's a time when you say that, okay, things are relatively stable, things can possibly get better from here as far as the health system is concerned. Do you get an idea as to where we are in that process?
Well, thank you for the question. Big question. My sense is that we are very early on in that process. For those of you who aren't familiar with the primary healthcare system in Ethiopia, it's kind of a three-tier system for primary healthcare, and the end point is that the lowest level of that is health posts, which are a very small health clinics, usually a nurse plus a couple of health extension workers. That's kind of spread widely throughout the rural area, and they're doing a lot of the basics: vaccines, treating childhood illness, and health promotion. So that tier of the health system largely collapsed in Tigray during this crisis. I know some of those health posts are back online, but it's a relatively small percentage. What I've seen in Northwest Tigray is that where there are still health extension workers, they've often been pulled into the facilities to work from there, doing the vaccines at the facility instead of going out into the community. And when I mentioned our community health piece, that is using existing health extension workers. So they're absolutely still present, and they're a skilled group of people, and we should be making every effort to use them. Shaylee, I think you were asking a sort of bigger question about the health system, and I think you almost have to kind of work through it tier by tier. I think at the hospital level, definitely capacity is very reduced. There were 5 kind of basic level hospitals and 1 secondary care hospital in Northwest Tigray. It's only the secondary care hospital that is now functioning. So you have 1 hospital for 1.7 million people. And that situation is probably slightly better in central and eastern parts of Tigray, but it's not dissimilar. So I think you need a period of stability. You need supplies to get through. You need salaries to be paid, there's work to be done with all of those pieces. I think the other thing to add is the leadership of the Regional Health Bureau has obviously changed during this process, and they are in the process of publishing a kind of response plan, and it'd be really interesting to see within that what their thoughts are around the health system. I imagine they will absolutely want to keep the health extension worker system going because it was very effective at decentralizing healthcare and improving access in the rural areas.
Right. Thank you for that. Here's a question for Dr. Nardos. James is asking a question about the brain drain situation. And his point is, what will it take for medical practitioners, skilled medical practitioners in Tigray to come back after the conflict? They're quite young, and there's a high likelihood that they would immigrate anyway. So what would it take to bring them back after the conflict is done?
I think, my experience working there with a lot of this amazing health champions is the passion they have for the work and the connection they have with the community and their commitment to this work. And their resilience. Remember, this population, this is not their first time going through conflict. So they're very resilient people. I think restoring peace is the number one thing. So they feel not threatened, and then they can getting, the support they need to practice medicine. That means rebuilding the healthcare infrastructure and empowering them to do the work. I think, personally, I think just, we need to do a lot of mental health counseling of healthcare providers. I think there needs to be that kind of support, ongoing support for a while to get people back. You can't ask healthcare providers to care for others when they themselves are traumatized. So I think that's going to be really important. And we've seen that in COVID here in our own communities. And I think that's really critical. But I think those are the ingredients, and just making it possible for them to be happy to be back.
You bring up a very important point. A lot of times brain drain is usually referred to from economic terms only. We don't talk about it from an empowering sense, the sense of how folks can be really empowered to do their work in their own communities. So thank you for that. Evan has a much more direct question, and all three panelists feel free to comment on this. This is probably one of the main questions we have in this age of information or misinformation. How do we follow the conflict in Tigray, particularly the humanitarian crisis? What would be reputable sources? Any thoughts?
I haven't found it. It depends on who, every angle of news that you get from any number of sources. I would include any number of reputable news feeds from the US, for example, or other countries. They all have an angle. I think they're definitely biased by their political affiliation, or whose story they decide to trust or believe, or who is speaking the loudest. There are certain groups that are speaking the loudest, and so their story gets told as if it's the truth. And what I find is alternative ways of thinking are not encouraged by any. So what I've been doing personally is, I am kind of in that middle. I'm kind of a bridge, I'm one of the few people in Ethiopia who is not from Tigray, but who have a lot of friends and connections in Tigray, but also my whole family and my own community is not in Tigray, right? So I get my sources from both sides, and then I talk to the people on the ground to the extent that I can. I talk to people like Joy, who is running a program on the ground. I talk to our colleagues whenever there is connection. I talk to people I trust on the ground, and then I try to kind of synthesize it for myself, what might be going on. But even then, I'm not aware really of what's coming in the corner. So unfortunately, I can't give you, my advice is, please look at both sides of the equation. Please talk to people across the aisle, even if you are emotionally not in a place to do so. I think that's the best way that we can start kind of to understand what's really happening.
Yeah, Bayan is a suggestion of getting your information from some community-based civic organizations, but even that, I think you need to balance. Other suggestions, Barb or Joy.
I was just going to suggest, I'm not as a panacea here, but in human rights terms, when I'm looking for credible information, I do trust Human Rights Watch to at least try to do a credible job of documentation. I haven't been following closely their work on the Ethiopian conflict, so people might have pushed back on this, but my sense is they at least try to document what's going on. A couple other international organizations that are worth turning to the extent they make their information public: the International Committee of the Red Cross, and also the Office of the High Commissioner for Human Rights. There are, as I mentioned, various special procedures. And so if you go to the Office of the High Commissioner for Human Rights webpage, and you look for the homepage on Ethiopia, you can come up with at least the overview of from the various treaty bodies and other agencies there. I feel like the Committee on the Rights of the Child has been particularly paying attention to the situation there. So these are not going to be like news reports on what's going on a day-to-day basis, but just in terms of reliable sources. Those are my recommendations.
Thank you for that. Here's a last question from Sue about, can mental health support be provided for providers virtually, and what is the technology and infrastructure in Ethiopia for this? Any thoughts?
Perhaps I can jump in. Absolutely, it can be provided virtually. I've seen that work very effectively in Syria, for example, using video consultations into Al-Hol camp. I think, however, Tigray is just at a very low ebb in terms of connectivity. So, there isn't any functional internet in the area of Tigray that we're in. There isn't any phone network. So you're kind of, the potential to get a good enough data connection to do particularly video work is very, well, it's just not possible at the moment there. That may improve, that may be different in other parts of Tigray, but at the moment, the connectivity just isn't there for that. Maybe Rahel has some thoughts as well.
Yeah, I was going to add, Shaili, there is an organization, the Center for Victims of Torture, that's here in Minneapolis, actually, and they have been in the Tigray region for the last 5 years, providing mental health services for internally displaced people, especially from Eritrean refugees in Tigray. And they're now trying to expand their services because of the sheer need of this kind of service. They're not yet in a position to be able to expand because their own staff is overwhelmed, and their own staff need mental health services. And I've been in communication with them, and I think their plan is to collaborate with organizations that are present in that area. They might reach out to you guys, Joy, to try to come up with a more kind of team-based approach to this mental health crisis. And they are in the position to expand their services to healthcare providers as well. So we're kind of in early phases of conversation as to what we can do. And there are definitely mental health specialists in Addis Ababa who know that region very well, some of whom are from that region, who want to collaborate with something like this. So my hope is that potentially we can train local teams who can then be able to go and provide the care locally there. But it's gonna, again, we need the area to be safe to be able to do that.
Thank you for that. I'm going to ask a panelist to come up with their final closing statements right now. Barb, if you will start us off on that.
Sure. I guess my thoughts in presenting it, so I always feel bad to present information and then say there's this huge compliance gap. But I guess the reason that states get attention for their human rights violations is because the public speaks out. It's a very basic part of this is that civil society needs to find its voice and use its representatives, either the US government or other governments or organizations working on this to demand more of an international response to what's going on. And things, there are many more structures and institutions than have existed in the past when these kind of internal conflicts would arise, and people outside of the country were absolutely helpless to work. So I guess I would just encourage our listeners to continue to take down information about what they're hearing, pay attention to information, and ask your congressional representatives to make sure that our State Department is paying attention to this issue and bringing the message to the Security Council as an issue of serious concern globally. Ethiopia is such an important actor in the region that it really has huge implications if there's ongoing instability. And so we need to demand an end to the conflict, but this kind of institution building with the attention of the international community. So I'd say keep on doing the work in the areas that you can, and it won't address all the needs that have been identified here, but I do feel like we can't make this an invisible conflict given everything else that's going on in the world. This is still a conflict of deep concern globally. Thank you. Thanks for the invitation.
Thank you, Barb. Joy, any final thoughts there?
Yeah, I mean, similar to Barbara, I think I'm just very aware that there's so much in the media these days that could take our attention, and just we need Tigray to not become a neglected crisis. So I'm very grateful for the level of interest, and I would encourage people to kind of stay aware, to keep educating other people about what's happening there, and to I think it's essential that the humanitarian response is scaled up, because this level of need can't be met by the kind of current health system by itself. So I think it's critical that access for agencies improves, and that the international community kind of engages with with that process. So those are my thoughts, really.
Thank you. Thank you for that. Rahel?
I like to count on our own communities in Ethiopia. We have a very rich culture, very unique culture in Africa, and we take care of each other. I just urge people to look beyond their differences by ethnicity and think about the humanity and the impact of this on just other human beings. I think there's a lot of distrust of each other, but also distrust of foreign players. I mean, there's a huge distrust of the US, by the way, in Ethiopia. The larger community of Ethiopia right now is very distrustful of the US because of US history in other parts of the world, but also just the fact that a lot of people feel like there is, again, a political angle involved. And so it is really difficult to balance that, given our history of colonialism and all of that in the African context, to reach out to big Western powers to help us solve this problem. And so I am just counting on the people themselves recognizing their connection and their humanity and their shared culture to come to a peaceful place and resolve this through conversation. and not necessarily rely on anyone. They can do this. So that's what I'm urging people to do, so we can do the good work.
Thank you again. Thank you to all our panelists for your wonderful insight into the very complex situation that's unfolding in Ethiopia. We would also like to thank you, our audience members, for joining us on this important topic. Many of you have asked a question about how to support, and we're going to show you this as two potential places you can connect. One is directly to Medical Teams International. Another is to our Global Women's Health portfolio. And feel free to go to those websites and offer your support as you please. One of the important things that comes up for us is, what are the other ways you can get engaged? I would encourage you to come out of our center website and see what are the other options for you to engage with our center. I'd like to also thank all our partners. As I mentioned before, this webinar is co-hosted by the Center for Global Health and Social Responsibility as part of the Women's Health, Equity, Empowerment, and Leadership series. And I got to thank the fantastic group of folks, the various centers and institutes within the University of Minnesota that are part of this. And you see all of them listed there. My special thanks is also to the G4 Alliance, which has co-sponsored today's event. I would encourage you folks to visit their website, the g4alliance.org website, to see their activities too. And then here is a teaser for our next webinar from Women's Health, Equity, Empowerment, and Leadership series. Can guaranteed income advance gender equity? This is a slightly different take. We're going way beyond conflict and looking at empowering women. And this will be on September 30th. More information to come. So I would encourage you folks to look at our website for further announcement for this. As I mentioned, this has been a pleasure for me, particularly to interact with an amazing group of panelists. My particular thanks to Dr. Hallam. I know he couldn't join us live. He put in a lot of effort in that video. Some of you still have some questions that are pending. I'm sorry, we are at the end of our webinar, and I hope you join us in the future. Thank you.